As the temps start rising, I feel the familiar urge to refresh my closet, but I don't want to waste money on pieces I'll only wear once or for just one season. Thankfully, Quince changes that. Their clothes are timeless, lightweight, and far more elevated than anything else at this price. It finally feels like my wardrobe matches my standards. The best part is that Quince only works with factories that use safe, ethical, and responsible manufacturing practices and premium fabrics and finishes, so you get to look good while feeling good. I'm pretty excited that I have upgraded my athleisure wardrobe for this summer. I bought a sweatshirt and a pair of wide-leg flow pants that are two of the softest items I own, and I plan to live in them. So join me in giving your summer closet an upgrade with Quince. Go to quince.com/POTC for free shipping on your order and 365-day returns. That's QUINCE.com/POTC to get free shipping and 365-day returns. Quince.com/POTC.
By the time someone's 85, some studies have reported 40 to 50% of the population has some form of dementia. Right now in 2024, there are about 7 million Americans with some form of dementia. The Alzheimer's type is the most common type. Only half of those are diagnosed. And of those that are diagnosed, half of them don't get diagnosed until it's obvious there's a problem. The person can't drive, they can't pay their bills. There's a functional problem. It's impacting not only quality of life, but potentially even safety.
That was Dr. Brent Forrester on Psychiatrist Off the Clock.
We are 4 experts in psychology here to bring you cutting-edge and science-based ideas from psychology to help you flourish in your relationships, work, and health.
I'm Dr. Debbie Sorensen, a clinical psychologist practicing in Mile High, Denver, Colorado, and author of Act for Burnout, Act Daily Journal, and the Act Daily Card Deck.
From America's Heartland, I'm Dr. Emily Edlin, a clinical psychologist based in Chicago, Illinois, and author of Autonomy Supportive Parenting.
Calling in from Vienna, Austria, I'm Michael Herold, ACT coach, confidence trainer, and author of an upcoming book on being a better conversationalist and making friends.
And from coastal New England, I'm Dr. Jill Stoddard, author of Be Mighty, The Big Book of ACT Metaphors, and Imposter No More.
We hope you take what you learn here to build a rich and meaningful life.
Thank you for listening to Psychologists Off the Clock.
Hi, everyone. It's Emily here, and I'm with Debbie to introduce today's episode. But first, we have a really big favor to ask of you. If you love our podcast, could you please go to Apple Podcasts and rate and review us? We would really appreciate it. It helps other people find us too. Thank you. I am here with Debbie to talk about my interview with Dr. Brent Forrester about his book, The Complete Family Guide to Dementia, Everything You Need to Know to Help Your Parent and Yourself. And I will say that subtitle is pretty accurate. It is pretty much everything you need to know. This is a very comprehensive book, and I think we were able to get into quite a bit in the interview, but of course, there's so much more that he has to offer in the book. But I want to hear what you thought, Debbie, of the interview.
I'm really glad that you did this interview, Emily. First of all, he's so knowledgeable. It was so interesting to listen to. But it's really important. I mean, it can be very scary and confusing when, whether it's someone in your life or yourself, it's your parent, your spouse, whoever it might be, to watch someone, start to get older and maybe notice some cognitive changes. And of course, these types of neurological conditions can be really complicated and hard to diagnose. And I think partly because the symptoms can be really different person to person. A lot of times the symptoms, it's unclear whether, is this normal aging or is this something I should be concerned about? And I've worked with people with a lot of different neurological conditions in my clinical practice. I've also had people in my family who are going through different concerns like this. And I think sometimes one of the things that's really complicated about it is that you don't really know, should I be concerned about this? Or is this normal aging? Is this something else like a medication side effect or substance abuse or insomnia or anxiety or depression or a treatable medical condition or something else? I mean, and I think it gets very scary and it's hard to know what to do. And so I think that this is really helpful to give just some straightforward information, but also encouraging people, maybe if you're not sure, to talk to a physician or talk to your primary care doctor or get a cognitive test going. And he gives some really helpful information for how to know, what should you be on the lookout for and what might it be? And so just really helpful to me.
I was really interested in the biology of dementia, which he gets into. And you're right, because these are neurological symptoms, there can be so many different causes. It is not a straightforward science. We know that a lot of times, for example, Alzheimer's can't be diagnosed until postmortem and looking at brain pathologies. And we have an interesting tidbit about what else has been found in those pathologies postmortem that is fascinating about dementia in general. But I'm going to save that for a surprise because I found it so interesting. But as much as there's a lot of information and understanding about the biological processes of dementia, there's still so much that is not clear in the lived experience with dementia. And so I think he does a really nice job of laying out clearly what we know and what to think about, and also acknowledging this is a process, and the benefit of being open to the possibility that what's going on in terms of decline could be dementia is the importance of earlier diagnosis leads to better outcomes. So I think this, if anything, if this episode can put that into the consciousness of adult children looking after their parents' well-being, that is a service in itself.
Well, and I also love that he really speaks to caregivers and especially to adult children of, someone who's potentially has dementia or whoever may be in the caregiver role, because I think that's one of the really difficult things is how the relationship changes and some of the demands on caregivers. And, I've done some work on caregiver burnout specifically. And I think it can be so demanding and so exhausting. And he really talks about, that it is okay to make decisions based on your own boundaries and what you're willing to do. And that it's really important to find ways to care for the caregiver in whatever way is necessary, because it's a tough thing to go through. I think sometimes, especially with more advanced dementia, it can be much harder actually on the caregivers in a lot of ways than on the person who goes through it. And so just really, really glad that he speaks to that, because it's I think going through an experience like that is really hard. And he's had experiences on both sides of that as well. And so it was really interesting and helpful to hear him talk about that.
Yeah, I think the part about boundaries is really critical. And there's even some good science to support how having good boundaries around the caregiver's stress and burnout actually benefits the loved one with dementia. And
Right.
So I think that piece of the interview will hopefully give permission to release some guilt that often comes up around, I need to do this for myself and feel like maybe I'm not putting my suffering parents' needs first. I think he gives a lot of permission to do that for the sake of your parent. And what I really loved in the book, and we didn't have as much time to get into it in the interview, but he gives really specific strategies for how to respond in the moment to, let's say, a parent who thinks they spoke with a loved one just who has died 20 years ago. And I never quite knew how to handle that moment if it were to come up. And I think he gives a really nice overview of how to handle those unexpected moments. And it's just a great roadmap for anyone in this situation.
Yeah, I thought that was really helpful, like how to navigate some of those relationship challenges with someone without it turning into a conflict. So I actually want to check out his book to learn more about that, because you did talk about it and I was really intrigued by that. I think that's super helpful.
Well, I'm so happy we were able to provide this as a huge source of support and a resource for our listeners who need it. And I hope everyone enjoys. Dr. Brent Forrester is the Dr. Francis S. Arkin Professor and Chair of Psychiatry at Tufts University School of Medicine. Psychiatrist in Chief and Chairman for the Department of Psychiatry at Tufts Medical Center, and Director of Behavioral Health for Tufts Medicine. Dr. Forrester spent a quarter of a century of his professional career at McLean Hospital in Mass General Brigham, where he served as the Chief of the Division of Geriatric Psychiatry at McLean Hospital and Senior Medical Director for Value-Based Care Solutions in the Population Health Management Department at Mass General Brigham. Dr. Forrester is an expert in geriatric psychiatry, specializing in the treatment of older adults with depression, bipolar disorder, and behavioral complications of Alzheimer's disease and related dementias. He is a past president of the American Association for Geriatric Psychiatry, a distinguished fellow of the American Psychiatric Association, and has previously served on the board of directors of the Alzheimer's Association of Massachusetts, New Hampshire, and chair of their Medical Scientific Committee. Thank you so much for coming on to Psychologist Off the Clock, Dr. Brent Forrester.
You are very welcome, and it's a pleasure to be here.
Well, you are a very busy person, and you have imparted a career of wisdom into the book we're talking about today, The Complete Family Guide to Dementia, Everything You Need to Know to Help Your Parent and Yourself. So first, thank you so much for writing this book. As you point out in the introduction, there's really nothing else out there like this guide for family members of loved ones with dementia. So I wanted to hear first a little about how you became so passionate about this field.
Well, thanks so much again for having me. And it's a great question, and it's one I get a lot. And so I'm a geriatric psychiatrist. I trained went to med school, did a year of medicine at Mass General Hospital and psychiatry at McLean. And I think there were two reasons why I wound up in this field. One reason was I had extremely wonderful role model grandmothers. Both my grandmothers lived into their mid-80s. They outlived their husbands, my grandfathers, who, by the way, were both physicians, but they outlived them by about 2 decades. And they both continued to work into their early 80s. So they were a wonderful model of successful aging. And through them, not only did I see about the positive aspects of aging, but I also learned from them and started to appreciate from them the importance of history and learning from one's history. And one of the things that I have always loved to do when I go visit people in their homes, which I've done a lot over the years, is to look at old pictures and to understand what their life was like when they were younger. So that's one. It's I love history. I love older adults and their history. And then my grandmother role models. The second is in medical school, what I really enjoyed was the problem-solving aspects of internal medicine. Having symptoms that really could be anything, and you had to figure out what it was, and there was a biological basis for it. I love neurology because I love the way that there may be changes that happen in brain function that could cause not just physical symptoms of weakness or tingling, but also psychiatric symptoms. And then in psychiatry, I love the human aspect of psychiatry. I love the fact that there were people who were struggling with emotional mental health issues that had both environmental and psychological bases as well as biological bases. And so as I went through my training, I found the field of geriatric psychiatry combines medicine, neurology, and psychiatry all together. And I am very biased, but it is by far the best field in all of medicine. And here's another little secret. Your listeners probably don't know many geriatric psychiatrists. And most people, including some of my colleagues outside of psychiatry, don't even know we exist as a field until you have a parent or a sibling or someone who's older who's struggling with anxiety or depression, or the early signs of a cognitive delay and you don't know whether it's due to depression. Or maybe it's due to alcohol use, which used to be just normal drinking for a 40-year-old now becomes a problem when they're older and their metabolism changes. Or maybe there are these medicines their doctors are prescribing that are causing a whole host of problems that are actually look like depression, but it's medication induced. So geriatric psychiatry is problem solving. It has amazing connections with people. Illnesses like dementia are not just about the person with the illness, but it's about the family. So it's a family disease. I love that part of it. It makes me feel like a psychiatrist when I work with families, and I do a lot of that. And then the thing that I started to learn in my career as it progressed is that after I became a lot more comfortable with caring for patients, I started to notice that our field was missing answers to a lot of important questions about how to treat certain conditions. As one example, I started to treat early in my career a lot of people who were getting older with bipolar disorder.
Mm-hmm.
And these were complicated folks in their 70s and 80s. They had had mania, recurrent, or depression since they were in their 20s and 30s. Or maybe they just got it for the first time in later life. Either one's possible. But now as they're older, they've got 7 medical problems. They've got 12 medications, and they're depressed or they're manic. And I go and look at the literature and the evidence base, and not a single study has ever been done on an older population that looks like Mrs. Jones sitting in front of me.
Wow.
And I'm like, all right, something's missing here. Luckily, I was at Dartmouth at the time, and I had great mentors. And my mentors were clinical researchers, wonderful clinicians and great researchers. I learned the value of research and the opportunity with research. And it was my experiences with those patients that sort of led me down the first part of my research career, which was, how do we understand which medicines would be effective in this population? I would put people on some combination and they'd get better or not, but I wouldn't know why. And I would have no way of predicting other than my gut intuitive sense after years of experience. So I started studying markers of treatment response in people with older adults with bipolar disorder, now depressed, based on findings with brain imaging, with MRI-like scans. And then I started doing a lot of research we'll talk more about in Alzheimer's disease, because I had a lot of experience with this population and the same exact problem. People with dementia get a lot of behavioral symptoms. They get anxious, they worry, they pace, they get depressed, they see things that aren't there, they're paranoid. And until a year ago, there were no drugs approved for any aspect of behavioral symptoms of dementia. And so we had no guidelines. And that was another area that I really started to get interested in.
Well, and it's so important that you start the book around the complex process of diagnosing dementia. And as you're talking, you're making that clear. There's all these neurological behavioral symptoms that can overlap and manifest from a variety of origins. So let's talk a little bit about if an adult child has a parent who they're wondering, is there a dementia process going on here? How do you prepare them for the process of diagnosing dementia?
That is another wonderful question. Can I just give a quick shout out early on in this discussion to my co-author, Tom Harrison?
Yes, please.
When Tom and I go around and speak to communities, public audiences, and professional audiences about this book, Tom comes at this book from a very different perspective than me. I come at it as a clinician with years of experience and as a clinical researcher and educator. Tom comes at it as an adult child of a mom with dementia. And Tom's insights are truly remarkable, and he has an incredible way of communicating this clearly, and it comes out in the book. But this problem that you bring up, I think, is one of the fundamental issues because, do we rely on families to prepare them for diagnosis of cancer or for heart disease? No. We have a medical establishment that screens for risk factors routinely in ordinary practice. Do we do that for cognitive changes? No. Why don't we do that? Well, there's a whole host of reasons. There are recommendations to build that into an annual wellness exam for someone when they're 65 and above. And the reason I just brought up primary care now for routine screening is because the family often, there are many reasons why there's a delay in diagnosis. By the way, I like to say as a level setting so people really understand this. Right now in 2024, there are about 7 million Americans with some form of dementia. The Alzheimer's type is the most common type. Only half of those are diagnosed. And of those that are diagnosed, half of them don't get diagnosed until it's obvious there's a problem. The person can't drive, they can't pay their bills. There's a functional problem that's impacting not only quality of life, but potentially even safety. Early symptoms can be very subtle. And most people will say, she's getting older or he's getting older. It's normal aging. Why bother? Or they're just worried or they're not sleeping enough or they always look for some other excuse. And I think the reason for that is twofold. Number one is they don't really know what the warning signs are, and how to differentiate because it's hard. Like what's normal aging memory decline and what's Alzheimer's disease, right? We could talk more about that. But the other reason is, I think, is fear. I think people are dreadfully afraid of this illness. And there's a lot of stigma attached to dementia and the Alzheimer's type of dementia. And I think that's one of the reasons and one of the barriers to early diagnosis is just fear, avoidance, denial, and and minimization because of the fear of what this could be. And I think the reason there's fear is because there's a lack of understanding of what this illness is, how it progresses, how people with dementia, despite the illness, can lead extraordinarily lives and be productive and impactful in their day-to-day and enjoy what they're doing and have meaningful relationships. Mm-hmm. And most people just see dementia and they worry it's the end. Okay. Right. If you think about the field, I brought cancer up already, but if you think about where cancer care was in the 70s, physicians often never disclosed to the person with the illness that they had cancer, or they whispered it under their breath to the you're looking like amazed, but this is the way it was. And partly it was because the treatments were horribly toxic, not terribly effective. Look where we are now. Everyone's marching and raising money for cancer care.
Right.
They're raising insane amount of money, and everyone's proud about that. People talk about having cancer. They bond with other people because they know that social connection will help them in their recovery. Same thing is true for dementia, but nobody is diagnosing it early on a consistent basis. And there's a lot of fear, stigma, and in some ways, even from the medical community, a term that I sometimes use is called therapeutic nihilism. So if I do diagnose, what am I going to do for treatment? And why bother diagnosing if there's no possible cure? And I would like to sort of shift people's frame of understanding to think about proactively, what can we do for people with dementia, as opposed to what can't we do or what needs to be taken away from them.
So what would be the benefits of diagnosing earlier than later?
So there are tremendous benefits with early diagnosis. One benefit is the person early stage, more often than not, depending on where in the brain the pathology is and how much insight they have. But more often than not, they know what's going on. Okay. And from the standpoint of agency and independence, most people would like to make some decisions about what they want their life to look like. So they get the benefit of being part of that process early on when their cognitive functioning is completely fine to be able to do that. People don't lose the capacity for everything all of a sudden. They lose capacity for various things over time. So making the diagnosis early is really important for engaging the individual with the illness in planning. Okay, that's one. Second is there may be other very treatable problems that are causing the memory problem. That's not dementia. We talked a little bit about this, but I'll give a few examples. There's a whole host of medical problems that masquerade as dementia. If your thyroid is underactive, as an example, or overactive, but especially underactive, you don't think correctly. You don't reason correctly. Your attention is off. It could be thyroid dysfunction. It could be a whole host of vitamin deficiencies. It could be untreated medical problems. It could be the use of alcohol at a level that now is not good for your brain, or it could be a medication you're taking prescribed or over the counter. So the list goes on and on. So one is identify treatable problems. You still may have Alzheimer's disease, but it's probably not as bad as you think it is because there's something else making it worse. That's highly treatable. So that's the second thing. The third thing is we are now developing treatments for the Alzheimer's type of dementia that attack the underlying biology of the illness, specifically the amyloid protein plaques in the brain. There's a lot of controversy about how critical it is to remove these plaques to see improvements and so forth. But suffice it to say, up until now, we've had symptomatic therapies that work for a period of time, 6 months to a year maybe. But no matter what, if you stop them, they lose their benefit. These drugs eradicate the biology of the pathological process, the amyloid biology. And the first drug was approved last summer. It's now on the market, called lecanemab. But it does not work for people who can't drive and pay their bills. By the time you reach a moderate stage of illness, we definitively know it doesn't work clinically. In the early stages, there's a good chance it will do something meaningful. And we can talk more about these medications if you want to, because there are pros and cons. But it's not just this one drug. We have a whole host of drugs in development and a pipeline of other therapies that are going to attack more than just amyloid. They're going to attack other biological processes. And the earlier we start, the better. And certainly for this drug, we know if we don't start early, we're not going to get anywhere. And then finally, what I'd say is, if you can start early on the dementia journey from diagnosis, then you have a chance to alter the course of illness through lifestyle modifications. And I think it's easy to say diet, exercise, but in more detail than that, the data from both animal and human studies on the beneficial effects of a diet that looks like the Mediterranean diet with high in antioxidants and green leafy vegetables and low in red meats and things like that, omega-3 fatty acids, we know that that kind of diet is very good for brain health. And we can't prescribe it, or we could prescribe it, but it's not a pill, so it's hard to change behavior. And then we know the benefits of all exercises, but especially aerobic exercise on brain functioning and brain health. So even with dementia, especially early on, you can alter course of illness and improve quality of life, mood, anxiety, and so forth with attention to diet and exercise. But you can also improve that with attention to social engagement. We have an epidemic of social isolation right now in our country, around the world. The pandemic brought that out. Older adults may be isolated physically, but sometimes they're emotionally isolated too. That's what's the problem. So social engagement is key. And then finally, we talk always about exercise of our bodies, but our head's connected to our body. And so we got to exercise our brain too. And it's not doing the same thing over and over again. It's challenging your brain with new things. So all of those 4 factors I just mentioned, agency for the person to help with decision planning, new treatments that might be available, altering the course of illness, and all of that, I think, is possible with early diagnosis.
I know Alzheimer's is what most people associate when they think of dementia. You do a nice job in the book of outlining several different types of dementia that wouldn't look like Alzheimer's. And what was really interesting to me is when you noted this study where they did autopsies of 1,000 people that showed they had pathology for multiple types of dementia beyond Alzheimer's. So do you mind just kind of clicking on a few of the other types just so we cover our bases?
What I'd like to do is start one step before that and just describe the difference between the clinical syndrome, which we call dementia, and the disease of dementia, which is a biological phenomenon, okay? There are 2 broad categories of clinical syndromes that we talk about in the book and that, you know, our clinical field talks about. There's the syndrome of mild cognitive impairment, or MCI, and the syndrome of dementia, okay? The syndrome of mild cognitive impairment, very, very basically, refers to some loss of cognitive functioning from your previous baseline in one of 8 domains of cognition, which could include memory, attention, language, etc. So decline in cognition, but generally speaking, the person's functioning really well. They may still be lecturing at a university, traveling around the world, giving conferences, running their own company. But there's some decline in functioning, but their brains are so well preserved otherwise. They have so many strengths that nobody really notices from a functional standpoint. So that's mild cognitive impairment. It doesn't say anything about what's causing it. It just says that that's the syndrome, okay, the symptoms. By the way, I often like to say it's like if someone coughs, do they have cancer or COVID? Or maybe they have an allergy, or maybe something got stuck in their throat just now while they were talking a lot. And if you don't know the cause, you are clueless about treatment. Okay. Right. We know about that with cough, but we don't always think about that with MCI and with dementia. So MCI is cognitive decline with preserved functioning. Dementia is when you have cognitive decline and now there's some change in day-to-day functioning. It could be relationships. It could be work functioning. It could be driving. It could be bill paying. It could be a whole host of things. When you have MCI or dementia, the next step in evaluation is to figure out why. Okay. There are many subtypes. Let's say we've excluded a psychiatric problem like depression or a medical problem like we talked about, okay? Then there are many causes like you were getting at with your question. If you look at the list of maybe 4 or 5 dozen causes of dementia, the most common cause is the Alzheimer's type. And this was a condition that was defined by Dr. Alois Alzheimer back in 1906. And his first index patient was a woman in her mid-50s. She was 54 at the time. And she was in an institution, and she was suffering from not only cognitive impairment, but she was paranoid about marital infidelity and had a lot of agitation. And after she passed away, Dr. Alzheimer, who was a neurologist, pathologist, looked at her brain and saw these sticky amyloid plaque proteins and these other abnormal proteins called neurofibrillary tangles. And those became the biological, pathological hallmarks of the type of dementia that bore his name, Alzheimer's. And at the time, it was thought to be kind of rare, like it was a rare disorder seen in midlife. But what was the life expectancy in the United States and around the world in
Right.
1906? It was
Right.
not 80 something. And so now what we've seen in our country as the first baby boomer turned 65 in 2011, which was only 13 years ago. And the last baby boomer is going to turn, 65 over the next decade. We're seeing a massive escalation in people turning 65 and older. And the number one risk for getting the Alzheimer's type of dementia is age. More than genetics, more than other factors we'll talk about, it's how long we live. So the prevalence of this in the United States in community settings is any dementia is about 5%, and people over the age of 65, nearly doubling every 5 years. But by the time someone's 85, some studies have reported 40 to 50% of the population has some form of dementia. But by the way, that means that 40 to 50% or 60% don't. Okay. So keep that in mind too. So anyway, number one is age. Alzheimer's is the most common form. The other thing that's important to remember about Alzheimer's disease is, and we can talk about this, like how do you do the evaluation? But the symptoms that often begin first are inability to learn new things.
Mm.
So it's the rapid forgetting phenomenon that frustrates people with the illness, but especially frustrates their loved ones. They keep repeating themselves. They're having the same conversations over and over again. They don't remember what they did yesterday. And it can kind of build up gradually. You don't really notice it. And they're like, this is happening all the time now. So that reflects the damage that's occurring in the hippocampus in the brain. The hippocampus is the part of the brain which stores new memories. The amyloid plaque and then tau tangles attack that part of the brain first for whatever reason. And that's why we see short-term memory loss, inability to learn new information as the hallmark symptom early on. Now, as the disease spreads through the brain, we get other problems, of course. But that's the first sign. I'm just going to talk about 3 other causes that are common, just so that not as common, not nearly as common. That's about 2/3 of all dementias. By the way, you asked another question, that the multiple pathology thing. The younger you are with the onset of your symptoms, like 50s, 60s, even early 70s, the more likely it's a pure one dementia.
Okay.
The older you get with the onset of symptoms, like into your 70s and 80s, which is pretty common, as we just talked about, it's more likely there are a bunch of things going on in your brain. So you might have the amyloid plaques and tangles in your brain, but you might have small strokes in your brain at this point because of years of, stroke risk factors and so forth. So people often, when they look at autopsy studies of older adults, especially 80 and above, will see more than one process going on. Beyond Alzheimer's disease, I just want to mention 3 others because they're different. They're different in how they present, and they're different in terms of their course of illness. One is called Lewy body dementia. Okay, Lewy body dementia refers to people who have a hallmark of 3 things. They have symptoms that look like Parkinson's disease. They develop tremors and stiffness, and they shuffle when they walk, and they're flat facial features. They have a hard time with their mobility, their gait. So Parkinsonian symptoms is one. The second are they often will experience these visual hallucinations that are very much formed animals, people, or other objects that they describe in elaborate terms without a lot of emotion connected to it. Like, I was just looking out the window the other day, and there are all of these animals that are congregating outside my house. It's kind of unusual. Like, where'd they come from? Or, I looked over at the couch and there are like 30 babies sitting on the couch and they're talking to each other, but I don't hear anything, but I see them. Isn't that curious? These are very discrete. Now, there are other causes of that, by the way, that have to be excluded. There are other focal brain diseases. There are medication side effects, et cetera, infections. But along with Parkinsonism, visual hallucinations, and the third thing is their cognitive challenges often are characterized by a rapid fluctuation throughout the day or over the course of days of their attention and concentration and overall cognition, so that they can look extremely clear and lucid one moment and very confused and impaired in another moment. And it's not due to an infection or a new medication, but it's the cyclical nature of this very challenging to diagnose and treat disease. There's an overlap with Parkinson's biologically and symptomatically, and there's an overlap with Alzheimer's. So you often see people with both pathologies, and sometimes clinicians have a hard time distinguishing. So that's Lewy body. The third is frontotemporal dementia. This is relatively uncommon, maybe 5 to 7% of all dementias. Lewy body may be 15 to 20%. This is maybe like FTD or frontotemporal dementia, maybe 5%. People with frontotemporal dementia often develop symptoms younger than Alzheimer's, like in their 50s and 60s. And the first symptom is not a memory loss. In fact, that's a late symptom. The first symptom is a change in personality, in behavior, in executive functioning, because frontotemporal dementia means this disease is attacking the frontal lobes of the brain and the temporal lobes of the brain. So you get language problems and you get problems with behavioral changes and executive functioning. So they may be on the apathetic side, or they may be on the aggressive disinhibited side, depending on where in the frontal lobes the brain process is striking. There are multiple subtypes, by the way, of frontotemporal dementia, and there are genes associated with that as well. And the final, fourth one, which is probably the second most common cause of all dementias, is the vascular type of dementia. Now, by strict definition, vascular dementia means you have dementia, like we described, the syndrome, but the cause is a stroke, which is either a bleed or a reduction in blood flow to the brain with a death of brain tissue. That happens abruptly, right? Strokes happen acutely. They're emergent. After the stroke, there's a decline in cognition and functioning, and then there's a stabilization until the next stroke, in which there's another decline. And people used to call this multi-infarct dementia. Now they call it vascular dementia, but it's a pattern of this stepwise decline. That type of pattern is the classic vascular dementia, but more often than not, people have more gradually developing symptoms, or it's more slowly progressive over time. And it kind of looks a little bit like Alzheimer's in that way, clinically, but they have these stroke-like events in their brain and they have vascular risk factors. So again, the older you are, the more likely you are to have the Alzheimer's vascular combo. But for vascular dementia, the purest form is the stroke stepwise decline type of thing I mentioned. So those are the four most common. There are many others. One other thing I'll say is there's some dementia syndromes that appear to be quite treatable or theoretically treatable. One is normal pressure hydrocephalus. This is a condition where you get a buildup of fluid in the brain and the ventricles of the brain caused by a structural problem, and it presents with urinary incontinence, unsteady gait, and cognitive impairment. And if you treat people early enough, you can actually relieve the pressure on the brain. You get not only does your gait improve, but you might also see some profound improvements in cognition. So the reason it's important to make the diagnosis is to treat what's treatable. You know, what's actually not just treatable with the ways we talked about earlier, but what's treatable in terms of reversible causes.
Right. Okay, this is an excellent foundation of knowledge. I want to move on to focus on the relationship that can change with the parent with dementia and their adult child, which is what your book's mission is, to optimize that relationship through guidance. And I want to start with a beautiful quote from the very first page, which is, "Our memory is, in a very large sense, our identity. It's who we are. Dementia doesn't just attack our bodies, it tries to erase our very selves." And I think that articulates so well why this is such a complicated disease on an emotional level, both for the affected person and the people who love them.
So thank you for reading that. And I hope that it encourages people to want to learn more. But I think that in some ways is the essence of the challenge of this illness. And there are a couple of things I just want to say. Number one, dementia is not one disease. We just talked about that. But what I also mean by that is, if you've seen one person with dementia, you've seen one person with dementia. Their experience of it, their awareness of it, they're willing to be part of the solution and the treatment planning. And then, of course, there's the family. And what does the family look like? What are their own dynamics? And what was the relationship between the adult child or the spouse and the person before they had dementia? All of those factors have to be taken into play. And that's one of the challenges that I think the healthcare profession has, is that there's so much to really think about. The other thing that you brought up is the relationship with a family member almost always changes when someone develops dementia. And people aren't usually thinking about that, talking about that, or frankly, emotionally dealing with that. When you have a parent, for example, with dementia, especially early on, all you know is your relationship with your mom or dad that you've had for decades. So as they experience changes, you might be afraid to sort of say anything because, well, out of respect, I would never do that with my mom, right? Or I always listen to my mom and dad's advice because they always knew what to tell me. Or the opposite, I've always had a really difficult relationship with them, and they continue to play it out as if it's due to the old dynamics, whereas it may be due to the new structural brain changes, which is bringing out a new personality or behavioral side of them. all of this is so hard for the family member who's wrapped up into it emotionally with years and years to tease apart.
Yeah.
This is why professional intervention and support, it's not just support of families and an emotional support, it's really an education of families. It's really a developing some resilience and developing an understanding of what's actually going on so that the family member can take a step back and separate what's my mom and what's the illness.
Yep.
And not got mad at the person because they're not doing a lot of this stuff on purpose.
Right.
And that's so hard. It's easy to say, and it's so hard to deal with.
Right. It is a brain disease that is changing our parent to some extent, and that extent can vary. And so along with that, our relationship changes and how we connect with our parent who we've known our entire lives has to change, which is a very emotional, complex process.
And part of that change can be the adult child. And again, this book was written for family members, but specifically for adult children of people with dementia. The adult child who's used to being, looking up to the respectful parent is now taking on some of the parental role. And not only do they have a hard time with it, but the person with the illness has a really hard time with it, especially if they're aware enough. I actually had my, in terms of my own personal experience with this last year, my dad had a number of medical and mental health issues and cognitive challenges around a whole variety of issues, right? And, he said to me at one point when he was in the hospital, "You're treating me like one of your patients."
Oh.
And I'm never going to forget that.
Yeah.
Because on the one hand, I totally got it. Like I knew I was doing that because my doctor brain kicked in and I was trying to make sure he was safe and being cared for. On the other hand, I knew how much he resented that. And what I said to him was, "I totally get it, Dad. Number one, I can't be your doctor, but I also, I want to be here for you, both as your son and someone to help you as a support person." But and he's a doctor, by the way, and he's still practicing. And so the whole role reversal thing, I totally get it. Now I really get it.
Which is important for your work to have that personal experience intersect. It's different being on the other side.
It's very different being on the other side. And like in the early days of when Tom and I started, before this episode occurred over a year ago, we had written the book and we were talking about the book. And, and it's been almost 3 decades caring for people with dementia or older with mental health issues. And having parent or parents with this illness, it just provides a different experience. It's almost like when you have a child, you can learn all you want to be, prepare for that baby, but until they show up, you have no idea.
Exactly. Yeah, I did all my training in child clinical psychology and became a mother and knew nothing.
Right, exactly. Well, that was the other thing I learned. You can know everything about your specialty, which my dad was experiencing issues that I've dealt with for a long time with my patients. And I might as well have been, a gardener or a teacher or a plumber
right.
or a fireman or whatever. The knowledge I had really didn't matter.
Yeah. And why your book is so powerful is it is so focused on the relationship. And I think that, there's a grieving process that has to happen. And you talk about that as part of what this is that's going on. And I think that's important framework for someone to realize my parent is still alive and I'm grieving the parent I've always known.
That is a very hard set of complicated emotions to hold at the same time. And I think as you're bringing out that we do talk about a lot in the book, grief is a big part of this process for families. And naming it is really important too. And helping families go through the grief process is important because their reaction to what's going on will sometimes be related to their own grief. And it's highly unproductive for the person with dementia.
Right.
If they're in the anger stage and the lack of acceptance stage, then when the person with dementia repeats themselves 10 times in a minute, they may lash out.
Yes.
And that's not good. And that intellectually, but how do you manage it emotionally?
Exactly. And this is what your book is for, because you provide some strategies and ways to formulate goals of being in this role with your parent that span all the different challenges. So I wanted to touch on what those are, and we can get into one or two of them. One is asking yourself what's most important here. Two is feelings, not words, focusing on how your parent may be feeling rather than what they're saying. Fixing and sympathizing. Reformulating the good enough relationship, and respecting your own boundaries.
When we started working on this goals topic, Tom honestly was, again, a non-healthcare professional, was educating me on what a goal is. Like, a goal isn't, I want to take my mom's car keys away, or my goal is, I want to have someone managing her finances. It's more of these things that are more emotional and more relational. You want to mention again the first goal?
What's most important?
And part of that goal of what's most important is what's most important to who?
Yeah.
Because the example that I think of in the context of what's most important, one of the things that families with loved ones who have dementia struggle with is a decision about how much independence or not their loved one should have. And the most egregious example of that, or the most and common, frankly, is when can they no longer live independently? And how many people have said, well, my mom said, never, ever do I want to be in one of those places. So don't you dare put me in one of those places, right? Does anyone with heart disease or cancer or diabetes say, don't ever put me in a hospital if I need to be hospitalized because of my condition? Never, never. And yet, for some people with dementia, the only thing that will help them be both safe and lead a really good quality of life is to be in an assisted living memory care facility, as an example. And I've seen people thrive in those conditions. So I think it's really important to understand, when you're making a decision, are you doing this for them, or are you doing this for you? And what I've seen countless times in my clinical practice has been family members who say, because of this, guilt around making that kind of decision, because of previous relationship and discussions with their loved ones, they're like, you know what? I'm not ready to do it. And I say, wait a minute. You're not ready, or your mom's not ready? Because they'll often say, actually what they say first is, my mom's not ready. Well, like, how do you know that? And then I try to help them think about whether it's for them or for the other person. So I think that's a really important thing to distinguish. The feelings, not words thing, it's very hard not to be hurt by words. Mm-hmm. They hurt. But it's also, and it's hard for families to understand that part of the communication that's going on is related to these structural brain changes. And the other part of this, by the way, is people may not remember facts and details, but they remember how they felt in the moment. And if you are thinking in your mind as a goal, what I want for my mom is in the moment for her to be happy, then that's the way you should talk with your mom. And not to dwell on what may have just happened that upset her, but to dwell on something from her past that she remembers fondly that you can reminisce about. But bringing out those feelings are really critical.
I love your examples in the book. I found them really helpful. And for example, if your parent is in the past and thinking that they just talked to their long deceased husband or whatever, focus on how they're feeling rather than saying, that's impossible. Your husband has been dead for 20 years. So say more about a more productive response.
A more productive response would be, tell me about that time that you guys were together. Where were you again? What was that restaurant like?
Yeah.
Or how did you feel at the time? I remember those days, or I remember that holiday, or something like that. So it really is to bring back the feelings that are positive. I mean, this is sort of the essence of reminiscence therapy in a way.
Yeah.
It's meeting people where they are at. And if they're at the past and the past is positive, then great. They may be in the past that's negative, by the way, too. So the past may or may not be perfect or good, but it's really the feeling about wherever they are, trying to redirect or correct them around lack of orientation, lack of what's going on in the now, for someone who's really not here right now in terms of what their orientation to it. will inevitably lead to an escalation in the person's own feeling of distress because they
Right.
will not understand now what's going on. What do you mean that person's dead? And then, of course, 5 minutes later, they'll be back talking about the person again, and they won't remember you've recorrected them.
Right. Right. So one thing I was surprised about that you did convince me, but it went against my all my instincts is, when is it okay to lie?
So we talk a lot about this, not only in the book, but it's one of the most common things we talk about when we're having conversations with communities and families. Because most people, of course, are taught never to lie. And they're taught never to, especially lie to a parent.
Right.
And they feel guilty. So it really is so circumstance dependent. And it's dependent on the stage of illness of their loved one with dementia and their ability to be aware of what's going on, like in their insight into what's going on.
Mm-hmm.
And so if the lie is really intended as a way to keep them safe, then that those are the kinds of situations. And some books, by the way, I don't think we may refer to it in our book. I'm not sure if we use the term therapeutic fiblet, but there are some well-known books that talk about therapeutic fiblets. It's really around redirecting them away from something that may be unsafe. And at the end of the day, what you're trying to do here is protect them from harm, either because of a feeling of harm that they may, an actual harm, or a feeling of being hurt. And there are many examples where not acknowledging someone just died, or not recorrecting them when they think that they've just been with someone who's passed away is one example.
Right.
Sometimes, here's another hard one. You're moving mom into an assisted living facility, but you don't give her a heads up. Are you lying? Are you just withholding information? What do you call that? How do you feel about that? Why am I doing this? That's where you need a coach. And actually, the coach could be a social worker, it could be a therapist, or it could be the amazing director of that assisted living who's done this 1,000,000 times and will coach you through the process so that your mom's transition or your dad's transition is as smooth as possible.
Right.
You don't want to do these types of things without guidance.
I was going to say, there are experts who are doing this all the time.
All the time.
Yes.
But for you, it's your one
first
time, and it's your one parent or your two parents or whatever, and your feelings and your relationships are why it's so hard for you.
Right. Right. So remembering the expertise out there and accessing those resources, because you're actually not alone in this, is an important reminder, I think.
You're never alone with this, but it feels that way.
It feels that way.
One of the reasons why dementia support groups, when they're done well for families, are so powerful is because not only do you learn tricks from other people about what they've done, because honestly, a lot of the stuff we talk about in the book are from, Tom's experience or my experience from having worked with patients or having family members, but you learn so much from other people and you realize you're not alone.
Yeah.
And this also helps to remove the stigma.
Yep. Very important and key to overall coping. And one thing you talked about that I wanted to just quickly bring up is a study from Berkeley that on average, people with dementia lived more than a year longer if their family members were mentally healthy and didn't let themselves become excessively stressed, anxious, or depressed as a result of their responsibilities. So that idea of also focusing on your own well-being as the adult child of a parent with dementia actually is helping with their dementia process.
The singular intervention that helps people with dementia is to care for the caregiver.
Yeah.
And that can take many forms. And I've had countless conversations over the years with whether it's a spouse caregiver or an adult child, they just trying to communicate the importance of caring for themselves and really going into detail on what that would look like, including getting some respite, taking time for themselves to do stuff that's meaningful. It's not always about having a therapist. It's really about what do you need to do in your life so you're doing things you love to do. And make sure that your mom or dad or spouse or sibling is in a good enough situation so that you're not worried about them all the time. But what I also say, and I never used to say this as clearly and as I do now, and I especially say this to spouse caregivers, because the spouse caregiver has a much harder time emotionally separating from the situation. And that's partly because of the nature of the relationship. And they've been married for, longer than the adult child's been alive. And, there's so many different dynamics involved. But I've told spouse caregivers, here's one of the problems. We know that if you don't take care of yourself, and we'll work with you on that, you're more likely to get depressed than not, right? 50% will develop a significant depression, not just mild symptoms, but substantial depression, which is not good for your health, well-being, or safety. And number two, and it's certainly not good for your loved one with dementia, but you're more likely to die. And some of my spouse caregivers have taken that to heart, and they've repeated it back to me over the years. And they've gone with me to talk to communities and said, when Dr. Forrester said X, it was a wake-up call. And others couldn't do that, and they did die.
Yeah.
One of whom died actually working at his desk at home and had a heart attack.
Oh.
And I am convinced the stress of caregiving was a big part of it.
Right. Absolutely. Well, your book provides a resource that is so accessible. It's such an amazing roadmap for anyone in this position and having this life experience right now. And it's chock full of other resources. So I think it's the roadmap that any adult child needs, or any family member of a person with dementia. It's incredibly helpful. So Dr. Brent Forrester, thank you so much for your time today. Thank you for the work you've done in the field of dementia and for writing this book. It obviously covers much more than we were able to talk about today, like when to take away a parent's keys, managing the other family relationships, and even how to pay for a care facility. So thank you for coming on Psychologists Off the Clock. Where can people find more about you and your work?
Well, first of all, thank you for your kind words. I do think the book has struck a chord in talking to audiences who have read the book and some of my own colleagues. It is a resource that isn't really out there right now. One of the points we make in the book is about how important it is to be proactive and not reactive. A lot of the things that Tom experienced and I've experienced through our journeys as caregivers and as clinicians really come out in this book. So you can learn more. First of all, the book is available on Amazon. It's The Complete Family Guide to Dementia by Tom Harrison and Brent Forrester. It's available through Guilford Press. There's information about me, a lot of information about me on the Tufts University Medical School website and on the Tufts Medical Center website and in my former home at McLean Hospital. And I'm also on LinkedIn, and I'm happy to connect with anyone.
Thank you so much for your time today.
Thank you.
Thank you for listening to Psychologists Off the Clock. If you enjoy our podcast, you can help us out by leaving a review or contributing on Patreon.
You can get more psychology tips by subscribing to our newsletter and connecting with us on social media.
We'd like to thank our podcast production manager, Jadine Stout-Williams.
This podcast is for informational and entertainment purposes only and is not meant to be a substitute for mental health treatment. If you're looking for mental health treatment, please visit the resources page of our website, offtheclockpsych.com.